my department, we have 10 doctors, but now they have to extend the patient and do some echocardiography. So they will come back here after, I think, 10 minutes. So I would like to start with my case report about severe tricuspid regurgitation due to ligament rupture suspected infective endocarditis, right ventricular cardiomyopathy. Yes. It is a male 35 years old. Since he was a child, he was not diagnosed with congenital heart disease, as well as his family history of no congenital heart disease. But 8 years ago, he was discovered severe TR accidentally after a chest tumor. He has been addicted to heroin for 5 years and has many tattoos on his body. He also has now a history of persistent fever, but about 3 months ago, he felt tired, shortness of breath gradually increased, pain in the right lower quadrant. And on physical examination, the patient had no fever, less weight with BMI around 18, skin with many tattoos, but no infected lesion. He feels dyspnea with SpO2 is around 93% at room air. He feels palpitation and on check congenital heart. He has regular fast rhythm, clear pulse, and have a 3/6 apical systolic murmur, and no signs of anemia, no edema. The liver is not enlarged and lungs are clear. On the chest X-ray, he has cardiomyopathy with signs of dilatations of right atrium and right ventricle, normal pulmonary circulation. And on the ECG, we can see the regular star rhythm with the inverse T-wave in V1 to V3, like epsilon waveform pattern. As a lab test, you can see most of the indices are normal, except the proBNP is green. And on the trans echo, thoracic echo, you can see the right ventricle is enlarged with this kinesia middle and a bit of poor free wall. And the LV seems to be small but contracted normally. Yeah. And you can see at the short axis view, many poorly differentiated trabecular in right ventricle reduced wall contractility. And the R tracks are reduced wall contractilities. The tricuspid valve annular dilated, and the tricuspid valve are not closed tightly. And on the 3D echo, the right ventricle has many unspecified trabecular. And the RV function is reduced, with the FAC is around 32% with low gradient between the right atrium and right ventricular. And on the echo on TTE and TEE, we also found the severe TR type 2 with the increased anterior leaflet motion owing to the leaflet prolapse that is secondary to the caudal rupture. Here the caudal rupture with a severe TR. And another view, two chamber views On the TEE, we also see the rupture of the tendon. Yes, and that is a button foramen over with the left to right side around 6 millimeters. We also do a MRI for this patient, and the result, the image shows enlarged right heart chamber, right ventricular function decrease, with the EF function is around 36%, and the suspected right ventricular myocardium because the regional RV akinesis without thrombus intracardiac, but during the delayed enhancement, there was no contrast. Enhancement was seen in all the left and right ventricular walls. And the patient was pre-operative diagnosis with severe TR due to ligament rupture combined right ventricular dysplasia. The patient was taken the surgery. During the intracardiac operation, the surgery was about the tricuspid bar. We see our vegetation is an injury caused rupture of the anterior pulmonary muscle, long posterior ligament, dilated annulus, and very thin valve tissue, but not perforated. We take some procedure for this patient. First, the surgeon suture the artificial ligament to the anterior margin of the left leg. The second step, he suture the anterior and posterior septal valve margins with the pollen and padding. They also set valve ring number 30, but they do not take the endomyocardial biopsy. And this is the picture of the surgery. Yes, here you can see the anterior papillary muscle is ruptured. And so they must suture the artificial ligament to the left leg. And after that, they suture the anterior and posterior septal valve margin with pollen and padding and put 30 artificial barbering. And on the post-operative exam, the patient has no fever with mild shortness breath and no edema with mild liver enlargement, and the rhythm and the heart blood pressure is normal. But he still has a 1/4 murmur in the 3-4 intercostal space in the pec. And on the chest X-ray after post-operative, we can see the heart is smaller than before. And on the echocardiography, we see that the tricuspid annulus is correct in portion with moderate tricuspid regurgitation within the annulus. The right ventricular dilatation and decreased contractility with FAC is around 18%. And we are waiting for the results of genetic screen and ECG Hunter. And the discussion about this patient, we have 2 questions. The first, is there any mistake in the diagnosis of the RV cardiomyopathy when associated with a severe TR secondary to the ligament ruptures? The second, I really want to know what can you do best or better for this patient? I'm really want to listen to your interpreting. Thank you.
Okay, any question from the audience?
Yeah. I'm listening.
No question? So, okay, I would like to invite Professor Lai. You have any comment for this case? It's adult case, not a pediatric case.
Yeah.
It's probably not congenital. I'm impressed that your surgeon was able to have only moderate TR after the surgery. That's actually very impressive. When I first saw it, I didn't think there was enough tissue to repair. So that's how much I don't know about the repairing tricuspid regurgitation. It would not occur to me, I guess in response to the first question, it would not occur to me that this is an RV cardiomyopathy because you have enough reason to see RV dilation and dysfunction just from the severity of the TR. So I would ask you, why do you think this is an RV cardiomyopathy?
Yes.
Dr. Zuen,
Okay.
Can you answer the question?
Yes, because at the first time I really concerned about the diagnosis because this patient have a severe TR. I don't know what happened first, TR first or the RV dilatation first. But we follow to the guideline about the diagnosis of RV cardiomyopathy. I think the patient have enough criteria to diagnose the RV cardiomyopathy, especially when I observe on the echocardiography, the muscle of the right ventricular is very special. You can see here is the on 3D echo. The right ventricle has many trapezius. It's very, it's not really like non-combustion muscle, but it's not normal. Yeah, in this picture, you can see the muscle of the right ventricular is not normal. If the patient have only the severe TR, I think the muscle of the RV is not like that. What do you think about this video? Professor Wing, you have a lot of experience on the cardiomyopathy.
Dr. Zuen, you have the detail about heroin addict for the patient.
Yeah.
When I was young, I saw many cases of heroin addict in Vietnam with tricuspid insufficiency. In case endocarditis in heroin addict, and we may have endocarditis in tricuspid valve or aortic valve. So I don't know what about the history of the patient. If the patient had with heroin addict endocarditis, we have tricuspid insufficiency first. Because the reason of the surgery is so good, I think more about heroin addict in the patient, not cardiomyopathy. But I have not enough detail, so I cannot answer for it. You can wait. What about the radiologist explain about MRI? Because with MRI, we can explain about cardiomyopathy. We can see, let you do gadolinium with the MRI or not, Duyên? Gadolinium.
Yes,
we have phase 2, you can see it.
Okay. Yeah, we also have the MR for this patient, but we don't have the gadolinium to check
Gadolinium do not have. Oh,
yes.
Very
So
sorry
on the
about
MRI, the physician cannot confirm that is yeah.
I would just say that when the RV gets dilated and dysfunctional, it can look like that even without a primary cardiomyopathy. And I would think with the history of heroin addiction, this is possibly just secondary to endocarditis. And he's probably had multiple cases, very likely been treated, and now has the consequences of severe TR over time, which is not common, but I think you can see this as a secondary dilation and dysfunction. So it might be interesting to get genetic testing. I'm not sure I would do a biopsy if your MRI was negative. One thing I would add is probably at some point you do have to wonder about arrhythmia risk. And this patient, I don't know if he had an EP study before the surgery and whether or not he had any additional work done on his heart at the time of surgery, that would be something I would think about.
Yeah, I also, because about the history of the DC, the patient was recover severe TR after 8 years ago, and 5 years ago he has addicted to heroin. So I don't know what is happened firstly, but I also find the symptom of the patient related to the arrhythmia, but the patient only feel palpitation, not feel other symptoms. But we also waiting for the ECG to find more information about the arrhythmia.
Okay, any question from the audience? Dr. Phúc, do you have any idea?
Yeah, for my opinion is I also thinking about patient have the endocarditis before and don't have the history is look like the myocardiopathy. Yeah, I don't think. Of course, we need to more information to definite the patient have the RV myocardiopathy. Yeah, and look like the cause of the just operation, the patient is very good. So I think it's, if they have the myocardiopathy, the ICU is maybe longer, progressive. Yes.
What about you think, Dr. THủy?
I also wonder about the patient with the many tattoos, and also with the history of the heroin addiction. The problem I wonder about the TR, tricuspid regurgitation severity after the chest trauma, up to the abnormality of the RV anatomy and also the function. We need to exclude the problem due to the RV, due to the TR first, due to endocarditis, I think. And also in this case, sorry, but I cannot see the sign of the cardiomyopathy, RV cardiomyopathy on the ECG. I cannot see the ECG to show more evidence to.
Jane said that she see an epsilon in EKG. So yeah, because of this epsilon, she thinks the person may have cardiomyopathy. But epsilon in EKG may see in another diagnosis, not only in cardiomyopathy, cardiomyopathy. Okay, Dr. Jane, you think that when you work for the future of this person, we understand it, the first thing. The second thing, if the patient had the children or not, little children.
Yes, I am waiting for the family screening with genetic of this patient. But because
that's right.
Yeah. But because in the north of Vietnam, the center of gene is not available. Yes, we have only one center in the Hanoi Medical University. But the gene for the cardiomyopathy is very difficult, unavailable. So
you can send to Ho Chi Minh City.
Yes,
We
Yes.
will ask for gene in examination in Ho Chi Minh City.
Yes.
And I think that Dr. Duyên, this very interesting case because for surgery of isolated tricuspid regurgitation is very difficult. We congratulate your surgeon because we have fear so much. We operate the left after and we do the right, but only right thing is very difficult. And so you will see the patient. I think that every 3 months for the patient. If the prognosis is so good, we think much about tricuspid regurgitation first. It may go the right vasodilatation, but I think it's very difficult for you to ask a person to stop heroin addict.
Yeah.
I have been in the heroin addict treatment for maybe 30 years ago. Nobody can refuse for heroin. And so it's very different. But you need to see the future of the patient. It helps us to understand about the diagnosis. But we can write the two things. The first is tricuspid regurgitation secondary by trauma or by endocarditis. And the second thing, we think about cardiopathy. Okay.
Okay,
And
thank
if you would like to study some gene, we have 3 laboratories for gene in Ho Chi Minh City. We can do this.
Yeah. Thank you very much. I will ask the patient and I will send your congratulations to the surgery team.
No, they are very good.
Yeah,
We fear so much. You fear so much. Okay, Phúc, you have the next. Okay, thank you, Dr. Duyên. Ca thứ hai lên trình bày.
Good afternoon, Professor Lai, Professor Vin, and all my colleagues. My case is a 1-month-old girl. She was diagnosed with a truncus arteriosus. She's a second child, full-term baby. Birth weight is 4.5 kg. Truncus type 1 with common arterial trunk from RV was detected by fetal echo at 22 weeks. After birth, the baby admitted to the NICU and discharged after 1 week with stable condition. Congenital heart failure developed after 3 weeks with sweating and poor weight gain. So now the symptom is a mild tachypnea and poor weight gain under a low dose of diuretic. And his current weight now is no weight gain, 4.5 kg, and SpO2 is 91 in room air when she's sleeping and 75 when she's crying. And the heart rate is 150 beats per minute. And the other is okay, regular heart rate and 3/6 systolic murmur. And EKG showed us is a sinus rhythm and right acid deviation and right ventricle hypertrophy. And the check X-ray is we can see the cardiomegaly. And the blood test is a little bit high of white blood pressure. And hemoglobin is 18 and HCT is 53. So NIPT screening for 22q for the job is negative result, and the mother decline amniocentesis. So because the baby was diagnosed with the truncus type 1 in 22, but she came to my hospital is quite late. It's 34 weeks, so the imaging of the fetal echo is not good. So here we can see it's a 4-chamber view. You can see a big artery from the right side. Big artery from the right side. This on the left side is the right side. And you can see it's a very huge artery. And it's divided into 2 branches. So this is a fetal echo. And when the baby give birth, we do the echo is a situs solitus, we can see here. And the IVC ran into the RA. So we can see clear about it. Look like the imaging that we record from the fetal. The big artery is from the right side, and it's divided into 2 branches. So here we can see in long parasitic, this view we can see is big artery is overriding, almost not just 5 to 10%, but almost is from the RV. And the valve of the common artery have 2 leaflets. It's a bicuspid valve. So we can see more about in 3D is bicuspid valve. And the regurgitations of the truncus is moderate. And we just have the my MR, my TR. And when we focus on this truncus in the common trunk, and we can see it's a very huge one here, and we see 1 branch here. And we can see it's connected to the descending aorta, and we see the branch here. And with the small one is divided in 2 branches. You can see here. And this one is mitral valve, and this one is a tricuspid valve. And we can see artery, coronary artery. It looks like a common one coronary artery. And when I check for the RV function, this is a reserved RV function with the RVEF is the 41%, FAC is the 39, and the free one is 12 minus 12. Type C is 6. With the truncus classification, we have Collett and Edward and Van Rapp classifications. So I have one small question to the audience, so that you can join with me with my case. What is a type of truncus that you think about? Is for result A is A1, A2, A3, or A4? Please make a bold. I see we have 30 answer already. Maybe we're waiting for 1 more minute. I see that we have almost 42 answers already. So maybe we next to so this one we can see is have for 47%. Sorry, may I see the result? So in the result of this case, we have a 47%. They choose the audience choose A1, this tab A1, and 33% is choose A2, 14% is choose A3, and 7% for the last one, A4. I will give the result later. So for this one, do we need any further imaging?
Can you delete the test for the easier to see?
Yes.
You can delete here or where?
Yeah. Do we need any further imaging? This for one is just enough, or more information from echocardiography, or we need CTA or MRI. So which one you want to choose?
Oh, you don't want to talk about whether or not it's 1 or 2 yet? Because I think the question you have to answer is what your next step is going to be before you say you need more information.
Yeah,
if you're going to do a full repair, you probably have enough information. If you're thinking of trying to band it, I'm not sure that you see well enough the length of the MPA and whether or not you can band it. But you've ruled out interrupted aortic arch. You've seen the coronaries, and the coronaries don't look like they're in the way. What you don't know is the length of the MPA, if you think you can band, or if you want to band. But at 4.5 kilos, I think most people would do a full repair, and your PVR has already dropped. So for doing a full repair, you have good sized pulmonary arteries. Your VSD is a little atypical, but I think you can baffle the LV to the aorta or the truncal valve. You have a bicuspid valve with mild regurgitation, but I don't think you need to do anything about that. So I don't know that you have to, although some surgeons do like cross-sectional imaging just to get the anatomy a little bit more. But if you're going to go for a full repair, I think you probably see it well enough. I'm not sure if you would consider doing a banding here, or you just go for full repair.
But sorry, that in your opinion, what truncus tab that you think about?
It matters much. To me, it's 1.5. I believe exactly what you said. It's most likely 1, but it's just the length of the MPA. It looks like there is an MPA, but it looks like it's very short. Yeah. So if you want to call 1, you can, or 2, you can also call it 2. But a short MPA that you cannot band is the same as a type 2, right? So then you do have to go for a full repair. At 4.5 kilos, most programs can do it. But I will say this is, in the 1980s, before they used to do Norwoods, and now, if you can do a Norwood, that defines what's a good program and not so good program. Before that is whether or not you can do truncus. If you can do this, then you were a good program in the 1980s, and if you couldn't do it, then you were not as in the top-notch program. So this is a very difficult lesion to do.
And do you think that the baby is now 1 month old already, and which time do you think is suitable for the baby to do the surgery?
Oh yeah. I think they used to wait till the PVR drops. So once your PVR drops, then you can do a full repair. I don't think there should be any problems at 4.5 kilos. I guess one other option, let's say you couldn't do a full repair because the kid had COVID or something like that, and you couldn't do it. The other option you could do for this case is you can do bilateral PA bands. I know some programs have started doing more of that. Before we used to say it's too hard, but then because of our experience with hybrids, we started doing more and more. And now, so let's say for some reason you couldn't do a repair because of infection or something else, then you could consider bilateral PA bands. implants. But I think most programs will go ahead and just do a full repair.
This case have a heart failure after 2 to 3 weeks.
Right.
And
You would be worried if you didn't have heart failure after 3 weeks, 2-3 weeks.
Yeah. Do you think that you need any more imaging for this case?
I think it's very program specific. I would be comfortable sending this patient for surgery. Unless I missed something.
We have operated this case in Heart Institute 20 years ago, only based on echocardiography.
Yes.
We don't need imaging because it was a baby 1 month. Because we did it in Heart Institute. If the patient type 1, type 2, it's easier for the surgeon to do it.
Yeah. Because this case, we have one, I think it's weird here because the truncus is from the right side.
It definitely is a more difficult baffle, yes.
Yeah. Normally it's from the left side.
Yes. Oh no, normally it's overriding.
Overriding.
50-50 is normal. Now you do have to make sure when you see it more off the right side, it's not because of mitral valve hypoplasia, but this mitral valve I think looked okay. I think this is just dextro position and just movement of the common arterial trunk. It's just an atypical variant of truncus.
Yeah. This case, because of the surgeon asked us for the CTA, so I do the CTA for this case, and we can see here and a very huge one from the RV, and this PTA here is stenosis from the day 1 or day 2 year 2 on. The PTA is open, the patent is very well, but now 1 month already, and this one is a little bit smaller. And PA branches is nice. And we can see here the coronary artery is very clear. And some have the airway is good, but the lung is we see something like that need maybe due to the heart failure and maybe due to the infection. And this one we can see very clear. It's an interrupted arch. So this one is aorta, and this one is Boomerang, and this from 2 branches is from Boomerang artery. You can see here. This one is aorta, and this did discontinuity to here, so interrupted.
Yes. Now you do have to think about that when you have bifurcation of the arterial trunk and it's equal size. Usually it's more hypoplastic when it's interrupted. But that just means we missed it on echo. That doesn't mean you couldn't have diagnosed this on echo. You should have been able to diagnose this by echo. So whether or not you say you need to do CT, if you keep on missing interrupted arch by echo, then you always have to do CT.
So I think we need to identify clearly the side branch of the aortic arch. I think the tip from the echo for this kind of patient is we need to clearly own of the branch of the aortic, for we can exclude it about the interrupted of the aortic arch.
Right. I think that's right. The only hint that I saw was that when the truncal root bifurcated, the ascending aorta then appears the same size. Usually you should think about it. You should always think about interrupted aortic arch and truncus. But if you have the same size bifurcating common arterial trunk, then I think you should think even more that it could be possibly interrupted aortic arch.
How about the 2 leaflet of the aortic valve? This can make it more difficult about the heart surgical?
No, I think it's just it will make it more difficult later on, but a bicuspid aortic valve is actually a very common thing in truncus arteriosus, and I think in short term it shouldn't matter. So I think this case teaches you have to be very careful when you're looking at the arch to make sure that you, like you said, identified each of the branches. But if you go back to your echo, could you find that you see something like any signs that this is interrupted arch? Because you did show a picture that looked, when you show that arch, that could easily be either arch. It's up to you to identify it, right?
So this one is Van Rapp A4, truncus arterius Van Rapp A4, and I find the Russell classification, and we see it's about the truncus. We have a pulmonary dominance or aortic dominance, and in this case, if the truncus is from the right side, I think maybe it's one of the clue that we have to think about the pulmonary dominance. And here is a pulmonary dominance with the aortic interrupted arc, and this one is a ductus is very big ones, and we have two branches is from a ductus. After the ductus here, you see, and this one is the aortic dominance. It's like the type A1 to A3. We usually diagnosis, and this one is for Van Rapp A4. And we can see that in the truncus, it's a 30% associated with the Dijon syndrome, and interrupted arch, like this case, is a 15%, and I find the other like HD or coronary anomalies is frequent, and incident increase in setting of maternal diabetes, and this mother is have a diabetes with uncontrolled. So the patient with treatment with the furosemide and verosperon with low dose, and this is a second child.
Spironolactone, not verosperon. It's a brand name.
I'm sorry.
Spironolactone.
Yeah, it's a second child and 4.5 kg, and the diagnosis is with the truncus arterius Van Rapp A4, and the heart failure is developed and without LV and RV function, and the result negative result. So like me asked before, is the time for surgery, total correction, and outcome. And you explained some before already. And how about the outcomes in this case?
Oh, I think you have to have a very skilled team to take care of this patient. He can be very sick afterwards. So we would do it now, especially if you're not going to put the child on prostaglandin, right? So now you have to worry about ductal constriction still. So we would probably do it at that time. And I don't know what the surgeon would say would be the operative mortality. It should be less than 5%, but it will be higher if you're not experienced to do the surgery.
Yeah, thank you for...
No, Dr. Lee.
Yes.
You have very interesting case.
Yes.
But after the result of CT, need to redo echocardiography.
Yes,
we need to find out why we do not think about interruption after interruption.
We do again.
Did you find out?
Yes, we can find it.
Can you explain it? Can you explain it for the young? We are young here. We need to understand it. After the result of CT, we need to redo echo.
Actually, this echo we do after this one. We do the... So actually, this one is a aortic, is an aorta. So, but we can see here it's not. We cannot see the aorta is like the normal. It's the we just see one branches separate from the other.
How to describe it is separate?
Because next view you can see this one.
Yeah.
Is aorta. Is an ascending aorta.
It's a supraortic view.
This one is yes.
Supraortic view.
Yes.
You can only see one branches.
Here we can see the PA, the ductus here through here, and this one is.
So this, if I can add, this is the for the young people, I guess. I don't know how many young people. But this is why we do sweeps, right? Everybody's used to just showing you one clip and then say, okay, this is this. But unless you go from right to left, and then you see that the ascending order went here and the ductal arch went there, if you show this to anybody, you can make them, you know, I'm not making excuses for me, but it's easy to see it and say, oh, that's what it is. When you're actually doing the exam and recording it, you should do a sweep. You should go from right to left. And then the other thing you need to show, which you didn't show, if you want to make the diagnosis, you have to do a suprasternal notch in a coronal plane, short axis coronal, and sweep it that way so that you have left, right, and you can see the two branches going in separate directions. That's how you make the diagnosis. If you only show a long axis of the arch, it doesn't. You won't be able, you can show that to 100 people, they won't be able to tell you which arch it is. So that's the teaching point, is to make sure you do a sweep from right to left. And if you do suprasternal notch imaging, you should include a short axis or coronal plane so that you can show the branches. So you know, if you didn't do it when you did the first study, then make sure, as you're suggesting, that you go back and figure out how you're going to make this diagnosis the next time. Because what could have happened if you're unlucky is this child could have gone home and the ductal arch could have constricted and he was shown up in septic, in shock. So that would have been, you know, this case you have a, now you're lucky he showed up in heart failure, not in shock.
I think your tip is very important because sometimes we only focus for the echo view on the book. We don't do the routinely the sweep, the rope. So I think it's your tip from we need to recognize around 6 seconds about the swap, the rope. I think that is a more important tip for difficult case echocardiography.
Okay, we move to the next case.
May I ask, did this patient have surgery yet?
Yes, the baby have surgery already and passed away.
It is a very difficult case. That's what I tell you.
I would like to present the next case is Dr. Yuen. The first case from Dr. Yuen.
Dr. Phúc. Yeah. So my next case will be present maybe 30 minutes later because my colleague is in the lab now.
Okay, we move another case. Can you show your case?
Yes, to continue with the programs, I will introduce my case today. Yes, I think that my case as stopover station on the road that we got the conference, and I hope that all of the audience will find something relaxed with my case. Yes, this case is a 7-month-old girl. She was diagnosed congenital heart disease in the fetal echo at the 17 weeks of gestation. And after being 7 days in NICU with a diagnosis of the DORV and coarctation. After 7 days after birth, a total correction of the double outlet right ventricle and repair the aortic coarctation was done, and the baby was discharged after 4 weeks post-operation. My patient is the first child in the family, which is only girl. a cesarean section, full term, and the birth weight is 2.8 kilogram. When we met her at the clinic, she still got the tachypnea and chest introing. Her current weight is 6 kilo, and the SpO2 is good in room air. The heart rate is around 120 beats per minute, regular heart rhythm, and 3/6 systolic murmur at the left upper sternal border. Chest introing around 55 breaths per minute. Both lung is clear and no hepatomegaly. The complete blood cell quite good. This is a chest X-ray. We can see some suture, and also the CTR is around 2.5. This is her ECG on that time. So the sinus rhythm about 120 beats per minute, and other not unremarkable. I will share with you some image from the echocardiography, the situs solitus, the left level cardia, and I tried to do the long axis view for this patient to see step by step, but at that time she's a little bit agitated, so this accepted view. Yes, and with Doppler color, we focus on the interventricular septum and also the LVOT. We can see the turbulence at the LVOT altar. And I'm focused here to see more no VSD residual, and also we can see the LVOT obstruction subvalvular. No aortic regurgitation noted. My mitral regurgitation. And there is something, the tissue from the LVOT is around 4.7 from the aortic valve here. And I also measure the pressure gradient at the LVOT is around 60 mm of mercury. And also the patient was done the coag repair. I also check the coag, the isthmus. The pressure gradient there is around 6 mm of mercury and no runoff. From the right side, we can see have no anything obstruction in the right side. Good PA. No residual VSD, and the pressure gradient there is quite good. Focus on the TM, good LV function with LVEF. Take home is 64%, but I noted here is LV thicken wall is increased a little bit. About this score for Detroit, score is +2. And the other function of the LV was done for the 4-chamber, 3-chamber, and 2 chambers. The global strain is around -15, reserve one. And on the right side, the free one strain is good, -22. I also check up the tricuspid regurgitation is the moderate, and no pulmonary hypertension. So the patient so far is treatment under furosemide and spironolactone. In summary, our girl is 7-month-old and shown far she was with heart failure, LVOT obstruction, moderate TR, mild dilated LV, and good biventricle function. After total correction of double outlet right ventricle and coarctation repair at the first week of age. So I hope that you feel free and wake up to do some quiz with me. Yeah, with the first one, questions, do we need more imaging tools for diagnosis in this case? First choice, with the echocardiography for checkup, this patient is enough. The second, we need more. We're using MSCT. The third one, need more, maybe both MSCT and catheterization something.
Đánh ép phải làm cái chuông reo reo reo.
Yeah.
Nghe rõ quá.
First time.
Okay, this is up.
Yeah. Yes. This case. Firstly, I choose this case to discussion today because I want to impress that the evaluation echocardiography after operation, after surgery, and one of the surgery that we usually see in our country is DORV, and with the DORV, sometimes the doctor just focus on the ventricular septum and also the PA, the pressure gradient there, and sometimes they forget the LVOT obstruction is one of the most important one, up to 10 to 20% in some research. And for this one, for this case, I saw here there are a lot of people, they choose the echocardiography, just the good tools for follow up this kind of patient. And MSCT or CAT, I added in this questions, maybe use it in the other situation. So can you for slide so as more indication or information that in which kind of the pressure gradient or changes in the LVOT that we need more CT something.
Now, this is a very unusual case. At least in my experience, to have sub-AS and DORV, I suspect that there was something there before the coarctation repair, and was only mild before, and then it became worse.
This patient diagnosed the DORV and coarctation in the other hospital, and they worse than the operation there. Yeah, right. I met them after the operation. Right.
This tissue, I mean, I guess it could have come just after surgery, but I would suspect that there was something there before, and this is not a common thing. When you say severe, usually when you get a peak instantaneous gradient of 60 in an unsedated patient, by the time you cath the patient, it'll be 30. And so probably closer to moderate sub-AS. And that may determine your decision, or may help you decide, or help form your decision whether or not you can go for surgery now, right? So the indication for surgery would be severe sub-AS. When we compare echo to the cath gradient, often we use mean gradients, and then you want to make sure you actually get the gradient from both apex, suprasternal notch, and right sternal border. And then in the report, you're supposed to say where you got it and the patient was unsedated. So there's in terms of severity of the sub-AS, it probably is closer to moderate, I think. And then for that reason, with no AR, and if you have good function, you maybe can wait till the child's a little better, just so that when you operate, there's less of a chance of recurrence. But the only indication for CT is if you don't know enough information about the arch, and if you weren't sure about the coronaries. But I suspect you had that information. You might want to go back and ask them if they had seen this, whether or not that's a surgery that they would have done. Sometimes you see this when the VSD patch bows into the LVOT, and when you have PS, but that you clearly showed that there's no PS. I'm going to guess the answer is going to be number 2 anyway, that you did a CT, because it's on there, multiple choice, but I don't know. Did you do any other testing after this?
It's just the choice that I added in this case to listen to the other opinion from the audience. Maybe in some cases, very difficult to see the structures, anatomy of the valve, and the others, especially the parts there, as you mentioned, maybe we need more MSCT.
Now, Dr. THÜI, if I see this case before, I will ask the result of echo just after the surgery, because after the surgery, when the patient go to hospital, we need to do echocardiography, and not 1 month, the first month, the third month, do echo. We see the sequence of echocardiography. We understand more. Did you ask for the result of echocardiography before?
The patient go back to hometown and we forgot to get that.
No, we can have contact with another hospital. You have the result of echo in that hospital. You understand more. If the standard progress, increase, it's a different thing. Because I have seen so many cases. Professor Kapongche, he have operated so many cases got atrioventricular canal. After that, the patient after atrioventricular canal, in some cases they must operate second, third time. When the patient progressive increase the stenosis step by step, but we need to check every echo before. We understand more about. I do not like MSCT very young. We do it. You love so much MSCT. I do not like it. No.
Now this treatment, the patient's being treated with diuretics, you said? So you do have to be a little careful of that. Because the function looks pretty good, so I'm not sure that I would want him to be on much diuretic.
Yes.
So what is the cause of the LVOT for obstruction in this case, for your opinion?
Yes.
You need to understand it.
Yes, going back to the imaging, we can see the, maybe it's the in the ORV we have got the double conus, and the conus is increasing day by day, and it's make the LVOT obstruction, I think.
There's conus, but that tissue you wouldn't call conal tissue. You would call it a fibromuscular ridge, and it's obstructing maybe progressively, but it is, what's unusual about this case is arising from the aortic mitral fibrous continuity region in posteriorly, and so this might be a very difficult lesion to repair. I mean, to resect. It will require a lot of close follow-up. I would expect it will increase though. The reasons for surgery would be if it increased to severe, or if you started developing aortic regurgitation or LV dysfunction, I guess. I don't think the LV looks like it's bad at all. Yeah, that's a very unusual case and unfortunate.
Yeah, no.
May I see your previous image?
Pardon? See what slide you want?
Just image that you show.
This one?
Yeah, this one. So I see this one is the VSD part is a little bit move forward to the LVOT. It's one of the cause.
It would be, but that would, to say it's RVOT bowing into the LV, you would have to have PS. But there's no PS, so that it would be unusual for it to bow into the LVOT if it's not PS. But that's something you should, right? When you were showing it, I was wondering if you were going to show that there was RV outflow tract obstruction, but it does not look like it.
Do you think that we do catheterization may help us about this?
So I think it's cardiac catheterization is not the role, don't have any role in this case.
Yeah.
So this is the second case I see the reaching from the posterior of the corner septum go up. And in reverse case, the first case I saw, so at that time is before I have the echo before. So at that time we don't have any bridging from the posterior corner septum go up to the anterior. So and this grow up very quickly after the surgical, and I think is due to the Dr. Lai mentioned before, the technical for repair at the obstruction in this position is very difficult. So that's also we bring patient here for ask the opinion. So I think it's attached to your question in next. I estimated you will ask about sale. Yeah?
No, to continue, I just discuss some about the option we choose to treat for this patient and how can we follow up them. Yeah. I also reviewed some research recently from 2010 up to now, and there are also many complications that they mention about the LVOT abduction. They mention if the pressure gradient more than 54 mm of mercury, we need to focus on the patient and regularly check up. Also in this other research, LVOT abduction is also the main reason for late onset that the operation for the patient after the biventricular repair of the DORV. And the other one is also mentioned about that. Some articles that I bring here just to remind us that we have to step by step, and when we evaluate the patient post-op, we need to notice on every place for the patient. So back to our case, 7 months over. So maybe Dr. Lai explained for us a lot, but should we choose the methods for treatment is my next quiz. Firstly, we continue with the medical treatment. We need to surgery. $50-50. 50 continue with medical treatment and 50 need to surgery.
What about the gradient?
60 mm of mercury.
60.
Yes, the pressure.
And the patient got heart failure.
Yeah, got heart failure.
If the patient had aortic stenosis, I do surgery.
Yes.
So one word for surgical.
Yeah, one word for surgical. Okay, this one I just mentioned about here for discussion, and okay, we also make the discussion with our surgeon, for example. But if in case of the surgeon need to delay the LVOT surgery at least 12 months after first operation, what is our role? The pediatric cardiologist needs to do now. First, convince the surgeon for the second surgery now because the baby need to. The second, increase the dose of diuretic. I think that the option Dr. Lai also mentioned before. The third one, keep low dose of diuretic at now and add beta blockers. The fourth, keep low dose of diuretic, add ACE inhibitor or ARB inhibitor, and maybe beta blocker. And fifth, change surgeon. Choose the other surgeon who sat with us for surgery for this patient.
Now I know I'm standing on my own here, but I would actually decrease the dose of diuretics, not increase the dose.
Yes.
So I'd be interested in your opinion on this, how easy it would be to fix this.
Yeah, the fifth one. General surgeon.
Yeah.
She would like to ask you, after the first surgery for double outlet radical, we have problem. Do you need to wait for 12 months for the second surgery? Or you can work earlier?
Yeah, it depends on.
No, you have to see the. You can't make an answer until you see the anatomy. But I think this is a tougher, as you mentioned, look, this is a tougher anatomy to repair than most for the sub-AS. But we'll wait. I'm sorry. This is out of.
Yeah, I will show.
Sequence.
I will show the imaging from the alveolar adjustment for Dr. Viên.
So there's some narrowing of the subaortic conus, and then in addition to the narrowing, there's a projection of muscle from posteriorly.
This is the case that we did.
DORV, total correction and coarctation repair at the first week of life. Yeah.
And we have a plan to redo it. Yeah. The problem of this case, after the surgery, we created the tunnel with the pericardium, and after the surgery, there are no gradient at all. But now after 3 or 4 months, we observed the obstruction, and now we plan to redo it again because it's the gradient now is
Quite high.
and it had and a reaction. The hypertrophy of the right ventricle, and we see it's an anatomic obstruction, and I think we should do it again to enlarge it, the baffle, and the cause of this case is I think it's shrinkage of the platform. We have some case like this. When we create the baffle, most of the case, if the diameter of the baffle is less than half of the circumference of the alveoli, the growth of the tract is quite good, but sometimes we have some case we have the shrinkage, and it have the patch become thicker and calcified, and we did remove the patch and replace by another material.
Yeah, I think that's when you do this repair, that you probably will have to look at that patch again and potentially, like you say, take it down.
But Dr. Viên, you think that the shrinkage, the calcification of the buffer in only some months is so quick?
Yes, we have several cases like that.
Something like that.
Yeah, but it's not frequent, but sometimes we have also the problem of we have some the outer pulmonary window, and we do the patch, and in such case the risk of the obstruction is less than the other, because it's quite easy to, and after 3 months the patch become much smaller, and we have to redo it again and replace by another material.
Do you do you routinely treat with glutaraldehyde?
Yes.
Yes. Okay. That's interesting. I think we tend to use, the surgeons tend to use Gore-Tex more where we're from, right?
So are there any difficult about technical to take out the bridge in the posterior of the LVOT?
I don't think so, because we can do by the right side, open the pulmonary artery, or we can do the unfibrotomy, and we can see very well the level, and we can replace it. And in this case, I think we should remove a little bit of the coronal septum, because we can see in the echo with some deviation, anterior deviation of the coronal septum as well. Mm-hmm. What do you think?
Posterior deviation, yeah, I think so. This is a trickier case than most, I think.
Because in the first attempt, it's very hard to it's quite small. It's just 3 kilos, and so that it's very hard to remove the coronal septum. Mm-hmm. And I think in the second time we try to remove the coronal septum. Mm-hmm.
Yes. And after the discussion from Dr. Vinh and also Professor Lai, em không biết sao nó tắt ra rồi, nó không có share được. Dạ. Còn cái kia nữa thì
How are you? Nice to see you.
Brian is out here.
He's out playing. But if you're available for dinner, I'm going back to the hotel to have dinner with him if you're available.
Yes, and after the discussion from Dr. Vinh and also from Professor Vinh and Professor Lai, I hope that you get something before we ending this case. After the patient doing the GORV correction, I hope that we also remember that one of the complications is the LVOT obstruction, and step-by-step view from the parasternal long axis view and also the apical view will give us more information about the morphology of stenosis, where is obstruction exactly, and using the color wave Doppler and pulse wave Doppler is very useful for us to evaluate the severity of them. And besides that, we don't forget to evaluate the function of the LV and serial echocardiography. For example, in this case, it's very important to detect the progression, and we should consult with the consultant for reoperate and the optimal treatment for this patient. Optimal treatment for this patient also on the debate. How can we use the diuretic? How can we use the ACE inhibitor or beta blocker, especially when the patient so small like this case, just 7 months old? It's very important. And I hope that we feel in choice with my case. And thank you for your attention. And we're moving to the new case from Hanoi, Tâm Anh, Hà Nội.
Okay, thank you, Dr. Thuy. Duyên, can you do your case?
Okay, my colleague is ready now. So He is sharing with us a case of coronary artery disease in adult. Please, Dr. Lam.
Hà Nội không có trẻ con, bệnh nhi hả?
So, dear professor and dear colleagues, today I will presentation the case about the anomalous left coronary artery origin from pulmonary artery in pregnancy. So the case presentation is the patient is 30 years old woman in the second trimester. Is actually in this time examination is 19 weeks. Pregnancy present with the chronic dyspnea on the exertion. She experienced worsening left side chest heaviness, and she hasn't medical history with coronary risk factor or no family history of premature coronary artery disease or congenital heart condition. The physical examination was normal, and her heart murmur wasn't recorded. EKG showed standard result without ST or T wave change. Ospetric ultrasound showed normal and amniotic volume with a heart rate is 146 beat per minute and fetal movement positive. And the biochemical biomarker is still normal. The NT-PNP or troponin T is still normal. The echocardiography show that we can see that the mitral valve regurgitation, and the test code method we cannot see the left ventricle dilation. The DT is still normal, 51 millimeter. And another view we can see the flow, continuous flow from the pulmonary artery. The echo show that the left coronary artery origin from the pulmonary artery. We can see the blue arrow, and the origin of the left main from the posterior to the right of the main pulmonary artery, which is very close to the ascending aorta that mimic normal origins of the left main from the aortic root. With cross-section will appear origin of the left coronary artery, but this is the dropout artifact. So we can see this is the endocardial fibroelastosis due to the ischemia is the higher echocity. So this view we can see that the collateral within the septal, a lot of the collateral in the septal. So this picture we can see the four-chamber view. We can show that fibroelastosis and the collateral within the ventricular septum in the five-chamber view. The patient had confirmed with the left coronary artery origin from the pulmonary artery on the MRI. So the ACAPA has a higher rate mortality in the adult patient. The uncommon features of the echo to the misdiagnosis result in delayed surgery to direct transfer and reimplantation of the anomalous coronary artery into the aorta is a preferred surgical technique, especially in pregnancy women. Increased cardiac event leading to increased mortality. I have the three small question is the follow-up every 4 weeks to check echocardiography to assess the progression of disease should or should not. And the second thing is, which is the best option for pregnancy, vaginal delivery or the C-section delivery with plan. And the last one, when we could operate for recovery after breastfeeding for this patient. Thank you.
Okay, I think that you have very nice case. I think the problem we can solve it. What we would like to ask Professor Lai, you would like to any comment?
This is the
This is very unusual, right?
Yeah.
Now, she must have like the world's largest collaterals because usually your right coronary artery is dilated, but this woman's left coronary artery was very dilated. So she just must have amazing amounts of collateral. Even though you have EFE, you don't have much MR. So she probably will tolerate the pregnancy fairly well. And the question for option of delivery is, where do you think you will have most hemodynamic stability? So if she has no other risk factors, I think some places might consider vaginal delivery, but I think most, the problem with vaginal delivery is you don't know what time of the day it will happen. I think not so much you have to, but I suspect most programs would opt for C-section because it's probably close to being as hemodynamically safe, but you can time it so that then everybody's there just in case something happens. I don't know if they showed anything else on the MRI in terms of, you did not give contrast, right, because of the women's pregnancy? I suspect.
So did the patient have the pregnancy that we didn't use or contrast or CT or MRI?
Yeah.
Right. So you won't be able to predict risk for arrhythmia, but I think because of the personnel availability, we would probably opt for C-section, even though that might not be absolutely necessary. And then for as far as operation for recovery after breastfeeding, this woman probably could have gone another 30 years before developing really bad problems, because every so often you see older adults with Al-Kappa who have abundant collaterals, they don't develop ischemia severely. So I don't know that you have to do it right after the delivery. But this is, again, a very unusual case. I don't know if anybody else has seen something like this one.
I have experience with the case of pregnant woman with mitral stenosis. You know that when we have pregnant woman with severe mitral stenosis, we would like to operate in the 5th month of pregnancy, because at that time you can preserve the fetus, the baby. We have experience in Heart Institute for so many cases. We cooperated with the obstetrician to operate for the patient. And this case, we have anomalous Unkappa, the coronary artery from the pulmonary artery. I think the pressure in the pulmonary artery is not enough to nourish the myocardium of the heart, and so the patient have heart failure. But in this case, we cannot predict when the fetus growing up. You know that when the fetus growing up, if up to the 7th month of pregnancy, the hemodynamic increase more than 50%. I think in this case, at that time, the heart cannot support it. So I like to operate for the lady at the 5th month of age with the cooperation with the obstetrician to preserve. You invite surgeon to re-implant the coronary artery. I think maybe the best option. I do not like to wait after the delivery of the baby. We don't know the future, so it is better at the 5th month. At that time, the hemodynamic is not so big, so it can preserve the heart of the lady. And for I do not like to wait for the vaginal delivery or cesarean section. It is better to operate youngly. Any idea from another person?
Yeah, some comment. We have in our series we have a not bad of Unkappa.
Unkappa, yeah.
And actually we have more than 100 cases Unkappa, And 10 years ago, we got a big problem with the ANCAPA because of the cardiac failure after the surgery. But nowadays we've got experience, and now the mortality is quite low. I think actually we have the mortality less than 5%. Even in the very severe case with the fraction ejection less than 30 or 20 even. But almost the case we do is in the before the 6 months or 12 months, and the recovery of the myocardium is quite slow. Sometimes it takes years to have the subnormal fraction ejection, and the predictor of the recovery and the mortality is the mitral regurgitation. If the mitral regurgitation is severe, it's very hard to treat it, because we don't have the repair of the mitral valve in such case is quite difficult, because it's not an usual lesion. And for the adult, we got about 10 cases. Almost of the case come with the mitral regurgitation, and we don't find we don't know it's an ANCAPA. And after this, and even we have the case that after the surgery, we don't have no idea about the ANCAPA, but it have the ischemia myocardium, and we do again, and we find out it's ANCAPA, and we redo it and do it again. And we have also we have the case that when the patient come the second time, do the mitral repair and discharge for hospitals, and several years is coming with the recurrent mitral regurg, and do again and find out it's the ANCAPA. We got a lot of problem with ANCAPA, and but in adults, the mortality is quite low, because of the collateral, and almost the case the tolerance run out of the patient is quite good, and it can go to the adult age. And in this case, I think the collateral is quite good, and the patient almost asymptomatic, and the dilatation of the left ventricle is not much. It's just I think it's just about 51. That's right. And my mitral regurgitation, and personally I think this woman can go to the end of the pregnancy, and we but we have to follow very strictly at the third semester. If I have a problem, we can do the cardiac surgery and cesarean at the same time as well. And the timing of the cardiac surgery, if it have an quite normal gestation, I think it depends. And I because it don't have any symptom, and sometimes I'm not sure that the reimplantation of the left can improve the situation.
Yeah.
Or just close. If I have a left to right shunt, just sometimes we just close the left man only, because when we do the reimplantation, we can see the competition between the left and the right. And sometimes in the adult age, when we do the reimplantation of the left, we have the myocardial infarction. Because the own of the myocardium is perfused by the right, and when we reimplant, there conflict between the right and the left, and some territory can have the ischemia. And I think if we do the surgery, we should have more investigation about the perfusion of the coronary artery, the anatomy, the perfusion, and I think it's better that we do after.
I don't know. I think this is a very unusual case. So, well, it is reasonable though to list what is the hemodynamic compromise, right? So, for pregnancy, you cannot tolerate pulmonary hypertension. You will have volume load, and you will have afterload reduction. None of those things should harm this particular patient that much. That's why I think you could wait, probably, but you would have to, as Dr. Vitt said, follow very, very closely. So what is the answer? What did you all do?
So for my opinion is, I think we need to close follow-up for patient on the pregnancy cause, and then after delivery, we need to check back again. Maybe we can done the stress test for patient for finding are there any ischemic for patient or not, for decision what we can do for patient.
Even though if the patient have no ischemic, so do we need re-implant?
Well, she has ischemia, first of all. She has EFE almost for sure, although we don't have the MRI with contrast. She has, if you don't do anything, these people will die a little sooner. And same thing if you don't reimplant, right? So we have experience with left main just ligation, and we know that those patients have poor long-term outcome. So I don't think not doing anything is a good choice, but the timing of when you want to do it. We don't usually use stress tests as a prognostic indicator, because you already know, at least if you're already going to go to repair, it doesn't really change what you're going to do.
My personally is I want to find the answer of your question in the reversely, why the connection to VA is bigger. So you see, look like the right coronary artery origin is quite not too big.
No,
when we compare with the connection with the left coronary artery to the main pulmonary artery.
I'm not sure it's not too big.
It's pretty big. I think that's the right on the left-hand side.
Okay,
right?
okay. For the speaker, what doctor? Dr. Nam, what you decide in your hospital? What do you decide in your hospital? You wait for the patient after to give birth to a baby?
Dear professor, my hospital is patient come to with the obstetric department, and the patient had the vaginal delivery with still normal, with no C-section, as everything is good after birth, and we don't know with the time patient to come hospital again to check about the cardiac, and we don't know how to recommend the patient because the patient had the good with a good function, the lab function, and no clearly the exertion were not clearly difficult to breathe when exertion. Just patient look like suitable with this situation.
Did you measure NT-proBNP of this lady?
The NT-proBNP when we examination is still normal, not increased.
Not increased. Okay, I think that you can follow up by measuring NT-proBNP every month for the lady up to the seventh month. It's the dangerous month for pregnancy. You can measure it. If after 7 months it's okay, we do not fear about heart failure. The problem is heart failure for this case. Up to now, no problem for the ischemia, you think?
Yeah.
So I think that in Heart Institute we have a thesis for a doctor. We are nearly on 100 cases. I will find out this thesis and I will show to you the reason after taking care of nearly 100 cases. This from my young doctor, Dr. THİO, for this case. Okay. I think that in this case we need to concern in the literature more for how to decide for the patient. We cannot answer now. After we need to discuss to find out in the literature for this case. But we need to follow up carefully for the lady, and you need to discuss with the family of the lady the danger of what about the risk of for the lady and the baby.
For the surgical point of view, I would like to do this case after birth.
Okay.
I would definitely say that long term it'd be better with reimplantation because there is going to be a risk of progressive MR. And the function can still deteriorate, even though she's only 30 and is already 30 and hasn't deteriorated. As they get older, there is slowly a more and more drop off of the function and MR increasing. So it's not normal to have collaterals like this. As the LV and aorta get stiffer over time, and the perfusion, coronary perfusion becomes compromised further, I think this woman will be in more danger for heart failure if you don't reimplant the coronary.
Now, every case I meet, I do reimplantation. Yeah. We need to do it.
Professor, in case of the ANCAPA in the children with the LV function impairment before then the heart surgical, how about the LV function in a long-term follow-up after reimplantation?
Yeah. Well, I think you know the answer to that. They recover slowly, their EF, but if you look at their strain, they have continued subclinical abnormality. So they never perfectly normal. And now they look at long-term outcome, and there's a higher risk of heart failure as adults, even after the surgery. So they look bad, really bad, and then they look very good for a long time, and then they slowly get worse, and they have I forget what the risk of dilated cardiomyopathy is, at least 30%. I think there's some studies out now that show that as adults, they progress and worsen. Yeah. So it's not perfect. We thought we fixed it and everything would be fine, but no, not perfect. But this case, the one thing, this repair, it's actually pretty simple. If this aorta, left main actually came all the way to the aorta, all you might have to do is unroof, because some of these left mains, they have an intramural course, and it may just be a simple unroofing. So this actually be could potentially be a very simple repair.
Before we did a different kind of surgery. We have to do the tunnel, intrapulmonary artery, but actually we just remove the left man and mobilize it and reimplant it directly to.
Right. But this one may already be next to the aorta, and this is a very tough diagnosis to make. So as a baby, sometimes these are missed because the left main comes so close to the aorta, so it'd be very easy to miss this. Very nice case.
Okay, Dr. Nam, thank you for your case. Okay, thank you. So the next case, Dr. Thâu, for sure.
Afternoon, I would like to present a case. The case is 3-year-old boy, current weight is 12 kilo. Patient have diagnosed absent type C of absent anomaly, have the soft spot for bilateral bidirectional clension, and tricuspid valve repair, and the patient reverse the patient had the BDA stenting. For the past medical history, the patient had in June 2019 in Children's Hospital 1, he was diagnosed with congenital after birth due to cyanosis because of absent type C, BDA, and after that, and then they sent patient to do the BDA stenting. 15 months later, he came to local hospital for treatment. After discussion for surgery, they decided to do clension and tricuspid valve repair. Currently, he's stable, no cyanosis, no dyspnea, no syncope, SpO2 94%, echo in upper and lower limb, no clubbing finger. The left lab test is normal. The X-ray is just myocardomegaly, normal pulmonary circulation. For the synerism, right seat deviation, just right atrium enlargement. I have some echo. This is cytosolitis, no interrupted IVC ran to the RA. Subcostal views, you can see level cardia and just to have a small PFO. In this view, you can see don't have the VSD, no MR, no AR, and just no LVOT obstruction. Good side of the BA and confluent BA branch. Don't have the turbulence in the PA, and we have the good side of the BA branch. For the four chamber view, you can see the enlargement of the right atrium, atrialized RV, and the septal leaflet display toward the apex. Elongation of the anterior and inferior leaflet. We can see the color flow of the tricuspid valve. For the Doppler, color Doppler, we think the patient have the moderate to severe, and also we assess by the client don't have the pulmonary hypertension. And for the vena contracta, the patient is around 5, and the ratio with TR check over right atrium is 27%. And so we do the TAP C and FAC in normal range, don't have the coarctation. We check for the clension, is right length is good, flow, left clension is good, and the pressure gradient is not high. So for me, is after the absent repair, is this enough information for tricuspid anatomy? We just need more technology to assess for the tricuspid valve. So I will, because we just 2 questions, so I move on the next slide. No. So we try to do the 4D echo to looking for the tricuspid valve. For this view, we can see from the red point is the septal leaflet, and we think this one the septal leaflet, and for the green we think it's inferior leaflet, and for the yellow one is we think the anterior leaflet, and also we think this one have the prolapse of the anterior leaflet here.
So when they did the initial repair, what did they do?
The initial PDA stenting.
No, I thought they did a tricuspid valve repair by lateral glen. So they did it. They already touched the tricuspid valve.
I don't think so.
No? Oh, I don't know.
You said that the tricuspid repair before.
Yeah, they have.
So they did it.
Yeah.
So I don't know what they did, but
I don't know why.
it's not. So it's moderate tricuspid, well, moderate plus maybe, but not horrible. When the heart size is not bad, and he's only 3, so he could go another 10 years maybe without having to do anything. I'm not sure that you have to do anything now.
I have an impression that they didn't do anything at the tricuspid valve because of the septal leaflet is quite still very low. If we do the reimplantation of tricuspid, will be below the same level of the anterior leaflet, and we don't have the prolapse of the anterior leaflet. It just because of the level of the septum is low and don't have the coaptation. It's just a real the prolapse of anterior leaflet. In the case like that, I think we should repair the tricuspid again.
Mm-hmm. Yeah, I think that's right. I agree. It's just a matter of timing. Usually this can be tolerated fairly well. The latest thing is most people in the United States are doing cone procedures where you would take down the leaflets, reimplant, reduce the size of the right atrium and atrialize right ventricle. Yes, this looks like a valve. I agree, doctor. Yeah, this looks like a valve that didn't get much work yet.
So this is we just start the 3D echo learning. Mm-hmm. So I think this is we using the 3D marker. So previously when I just start learning about the 3D echo, the most difficult for me to learning is I cannot identify where is anterior, where is posterior, where is septum, everything. And in this one, we can get the 3D marker is very helpful for us to identify exactly where is the anatomy relief for anterior, posterior, and anterior leaflet. And I want to ask Dr. Vinh, do you think that's imaging will be helpful for you before you go in for tricuspid valve repair? If you go in for tricuspid valve repair, so you think that's amazing helpful for you?
Yeah, I think it is good. You have a beautiful picture of the tricuspid, and I think it's very useful.
I think we would always try. I do have a question though. It's unusual to stent. This child was what, 1 year old, and you stented the ductus. Was it and what was the reason to stent the ductus as the first procedure?
We don't know.
Stent or occlude?
Stent.
I don't understand why we need to do a stent. PDA. Children's hospital, right?
Yeah.
Just sometimes in a neonatal abstent, sometimes we have very severe case with very low SpO2, very cyanotic, and the cardiologist like that in the pediatric hospital, they don't have any option. Just put the stand to improve the SpO2.
Right. I think nowadays the trend is more for trying to close the ductus, rather than keeping it open. And I think if you stent, those are the patients you commit to a single ventricle. Here, it looks like you wouldn't be heading down that route. And in some cases, we actually ligate the ductus. So I was just wondering the rationale or reasons why the kid had a stenting instead of his.
And you can explain why for
right, because when you have elevated blood flow from a ductus, and what happens is then you have less forward flow and then more regurgitation and more PFO right to left shunting. So the trend has been to actually close the ductus with medication, and or if failing that, then to ligate the ductus and attempt to improve forward flow across the RVOT. So there's no one answer, and I think if you have a Sinek baby, you don't know what to do, you might consider that. But now our trend is more toward trying to remove the extra source of pulmonary blood flow.
But in such case, what can we do to improve the saturation?
Well, you suspect that if you improve forward blood flow, you have less right to left shunting across the PFO, so your saturation should be a little bit better. Now, if that doesn't work, of course, then you do have to do depending on the age that you do it, you might consider do the bidirectional Glenn at that time, if you're already older. But these can be tough choices. It's a little unusual, though. I don't know how old the child was when he had the stenting done. It looks like he was a few months old, right? So,
Dr. Thom, do you think this case has indication for tricuspid surgery now? In this case now?
Actually, because I think the patient don't have heart failure.
No heart failure, right heart failure, no.
Yeah, no heart failure. And also we try to assess the RV size.
Because in F-stand disease, we have indication for surgery. It is very difficult.
Yeah.
So many cases, I see surgery after doing it, the reason is not good. So we need to follow up the right indication for surgery of F-stand disease.
Yes, that's why I bring the patient here to ask, because this patient, I also try to assess the TR is just from the moderate to severe. The patient stable on medical treatment.
Yeah. And can you say us about the experience, about the classification estimated about how much of the TR? Because now it's very difficult for identify, especially in a small kid.
Yes.
When I contact, everything is sometimes not correctly, because in the 3D angiogram, some view is big, some view is small, and also is enlargement of the RV.
Right.
So TRZ in the RA ratio is not so clear.
I think everything is a guess. It's a guess by echo, 2D, 3D. It's a guess by MRI. You usually use saturation and exercise tolerance as the indicator.
Yeah.
Right. I think you have multiple jets. They're going in funny directions. You can't assess the RV size well because you can't see it well. Even by MRI, you can't assess the RV size well because it's very hard to get the plane of the tricuspid annulus. So it's all a guess. And so somebody invents something brand new. There's no way to assess the severity of a TR well enough to follow clinically. So for clinical indications, it's usually symptoms and cyanosis or cyanosis with exercise. So those, and arrhythmia, sometimes you have to go in and do something, but those would be the indications usually for intervention.
Sorry, in this case, if we do the surgery and we repair the tricuspid valve that we think is successful, we need to take down the gland and reimplant it to the RA. Do we need?
I think that would be a consideration depending on what you think your RV size and function are. So if you think your RV can handle it, then it might be useful. But on the other hand, it's probably not harmful to leave it if the child's tolerating it. So if anything, I think most people would probably just leave it alone.
So if at the beginning, when that the first time that the patient had the surgery, so if we have a good surgeon something and we can repair is good, so we need to do the cleansing in for this?
No, I think if you do, most cases you don't. Most cases you do a tricuspid valve cone procedure and restrict the ASD. That's all.
It depends on the hemodynamic. After we win, we win the CPP. If the pressure, the right atrium pressure is quite high, and we have to do it's
right.
On the medical report, they try to do the biventricular repair. How they cannot.
Right. Yeah. So no, I agree with everything you said. But your question is, now you already have it. Would you take it down? That's a harder decision.
Maybe we should leave it alone. Is better.
Hello.
What about the PDA now? It still have the blood going out.
No, they take down the PDAs and when you do the repair and cleansing. Okay. So now I would like to invite Dr. Cook. So and we. So I also try to estimate for the biventricular function. This is of 4 chamber, 2 chamber, and 3 chamber. I try to do speckle and good GS for the left side, and the free word of the right side is minus 15, and also we try to do the 4D function. We try to do a 4D function for this patient. However, this is for us maybe it's not correct because all the leaflets is not on the same plane, so we cannot have the correct volume of the right side. And I would like to ask, do you have any?
That's true. It's just that with Epstein, it's very hard to know where to draw the plane with the AV valve. So and even by MRI, RV ejection fraction just rough estimates. Not very accurate.
Yeah. Yes, and this one we have some. Make just some parameter recommend from the ESC for to evaluate the right side. Yeah, and also one trial public in 2020 from the Beijing Housing Hospital. They recommend to also use the strain rate before and after operation to see the RV function. Yeah. Patient on treatment. So for summarize, we keep the patient, we close follow up this patient because we estimate the patient have moderate to just severe. However, the patient don't have the symptom tolerate with the treatment, medical treatment.
How to assess RV function? That's just to blow it off, but it is very difficult. You still can probably do capsular fraction area change. Maybe for the EF. Probably what I would recommend is whatever you do, you should just do the same each time you see the patient so that you can look for any change.
Yeah. Okay, thank you.
Okay. So this case is we bring here because after the Epstein anomaly follow-up have a problem because it's very difficult for assessment about the TR and assessment about the RV function. So we bring the patient here we can try what we can do and show you what we do. You can have us to add any tip for assessment about the TR and the RV function more. So when we try to do, we learn a lot because we know how to difficult to assessment of the TR and the RV function.
Right.
Yeah.
Right. I'm afraid I don't have many tips. Yes. You're doing everything. The only thing that you didn't show is DPDT. That's also very highly variable, B2B, and study to study. It's hard to get reliable measurements for DPDT. But as I said, whatever you do, you should just try to do the same thing each time you see the patient. So you can, at least in your hands, you look for any change. But I think the main way we follow these patients, as it says, is symptoms, exercise tolerance, and then saturation.
Dr. Kirkpatrick, we write a chapter about right ventricular function in Catherine Otto echocardiography book, but it is very difficult.
Yes.
Okay, thank you, Dr. Thong.
First one, I want to thank you for all of the audience can stay until now because it's a last case for our webinar. So, and I will try to show something don't make you sleepy. So this is a 15 years old girl. So current weight patient is around current weight is 33 kg. The patient was diagnosed is a double outlet of right ventricle and pulmonary atresia. So past medical history, that is the first children in 2 children family, spontaneous delivery, preterm birth weight is 36, birth weight is 1.8 kg, detected congenital heart disease at birth time, and in 2009, the patient done a modified petition before, and in 2013, the patient failing gastrally operation with the VD closure and transferred to the bilateral bidirectional cleanson. So currently now, she has got Morex cyanosis, no dyspnea, no syncope. The saturation of patient now is around 76% on room with clapping of finger, increasing of the red blood cell and high SCT level. So chest X-ray patient have the normal heart size and normal pulmonary vascular marking and spine scoliosis. So EKG is patient have the sinus rhythm with the Norwest axis, VRS axis, and the right ventricle hypertrophy. And I want to show some imaging when patient came with us. So that is situs solitus for patient. The patient have the level cardia with the apical in the left side. And in the parasternal long axis view, we can see the patient have the muscular VSD, maybe 2 horns. One is very nearby of the apical and one just upper lip. And we can see the patient have the bidirectional flow through the muscular VSD here. And in the 4-chamber view, once again, we can double check about the bidirectional flow in the muscular VSD. So back again in the parasternal long axis view, we put the color and we see what is in this imaging. So we can see some calcification here, very surprise of the membranous. So we thinking that is the rest of the VSD passed closer before, and we can see the turbulent flow in the LV outflow tract, and the aortic valve is a bit higher. And in here, we also see the bridging from the corner septum grow up from the posterior, go to the anterior. In same case of the Dr. THủy patient previously we discussed. So, and also in the anterior, we can see that is the path from the VSD here, go up to the anterior of the aortic arch, and we can see the flow from the right ventricle go through the path and go to the aortic valve, and we don't see any turbulent flow in this position. So, and we check the pressure gradient trunks, the LVOT is not the significant stenosis, and also the pressure gradient through the RVOT is not obstruction. So that is the shock axis view. We can see the 3 leaflet of aortic valve, and we didn't see any the pulmonary artery arise from the right ventricle here. So this is a aortic arch. We don't have any coarctation, and not don't have any collateral from the aortic arch and descending aortic. So this is a Clanson in the left side. We can see the SVC is dilated is here and connect to the PA at this position, and some collateral behind the left SVC, but the flow is not so clear. So then I reduce the scale in the color scale, and we can see more clearly about the flow from the SVC in the left side and also in the right side. And we don't see any turbulent flow in the connection anastomosis between the SVC to PA. So we think the patient don't have the stenosis at the clanson. So back to this one, we check the estimated about the function. So LV function is around 70%, Simpson is 55%, RV function is with the TAPSI is reduced, it's around 12 mm, FAC is 42%. But we can see in the right ventricle here, in the apical of the right ventricle, so it looks like the wall of the RV in the RV apical is thin than we compare with the other region, and look like it's aneurysm. So do we need any more information from the echocardiography just enough, or we need to more anatomy about the LVOT or RVOT, or do we need to assessment about the more LV and RV function and other? So most of people want to know more amazing about the anatomy of the LVOT and RVOT, and also more information about the RV and LV function. And so we also do like this. So
just as you're pulling up the next slides, by history, what did they do for the RV outlet? Did they do an RV to PA conduit?
Yeah, drastically operation RV, and they take out.
They
out the RV.
Took that away completely.
Yeah.
So I wasn't sure that was there a significant residual VSD at the patch area? So the patch is halfway taken down.
So they tell is they take out the VSD, but as I see on the echo, look like they put the hole only. They take not totally take out all of the VSD patch.
But they took it out partially.
Yeah.
So it's ejecting out the hole in the VSD patch.
Yeah.
Okay.
So this one, I think that is the rest of the VSD patch.
Right.
So,
if that is the case, then I would just say you can't really say there's no LV outflow tract obstruction based on the gradient, right? Because you have a systemic RV pressure, you have a systemic aortic pressure, so your LV pressure is going to be equal. So there's never going to be a gradient across the LVOT. So it's only an anatomic diagnosis. To me, that LVOT looks small, and you cannot, so you're depending on two ventricles to eject to the aorta. So I guess that's the only thing I would change about your diagnosis. I think there is LVOT obstruction. So, and if you were to redo it, you have to redo the entire patch.
So I also thinking about that we underestimated when we measure the pressure gradient from the LVOT. So because we still have the anatomy is very tiny stenosis, and also the patient have the muscular VSD. So it's make the pressure gradient through the LV and RV the same. And the other thing is we still have the area before we the distance between after the nail ring here and the aortic valve. So we still have the area. It's make the pressure gradient through the LVOT is not obstruction. So we try to do the 3D echo for see the pus, are there anything. So that is we see in a little bit lower in the apical, and we see that is the mitral valve in the posterior here, and see back that is the aortic valve in the reversely, and this is a hole, the back of the hole from the pericardium pus. So that's why I can explain don't have the obstruction in the RVOT. So using the 4D marker for check back again, the whole they have the markers here. For see the aortic valve is in the posterior. So that is the symptom by the 4D of the LV. LV function is around 50%. So we also try to more estimated about the LV function by using the trend, and we can very surprised because on the 2D it's quite look okay, but when we do the strength it's reduced. But maybe due to the something we can have the some whole VSD, muscular VSD here, maybe the striking of the strength is not so good in this area, but for all of the totally of the trend is reducing for all of the wall of the LV. So do we need more imaging? Just enough, or we need to cardiac CTA or cardiac MRI, or we need to both? So we have a lot of idea. So how about your opinion, Professor Lai?
You want to see, I think, whether or not you can do biventricular repair. And if you want to do that, we would do some form of axial imaging, either MRI or CT. And in most institutions, they would create a 3D data set so that you can figure out how to do the baffle. You want to see if you can reach the VSDs in the apex. You may need to do that per ventricular closure at the time of the OR. Then you redo the LV to aortic baffle, and then see if you have enough volume to connect the RV to PA conduit. I probably would lean toward a CMR so that you can get both volume and ejection fractions for both ventricles.
Choose the cardiac catheterization. Maybe Dr. Chi Nguyễn. Yeah, she shared the points.
Yeah.
Mm-hmm. But what a pity that she cannot give us the opinion.
No, you would do. I think you probably end up doing a lot of, because this is a big decision to go for biventricular repair. You probably want to make sure that you can pull it off.
Dr. Phúc, this case we have VSD, muscular VSD next to the apex. It's very difficult to do parallel repair.
I was saying we would do it perventricular. So you put a catheter at the time of the OR. So you open up the heart and then do a device closure at the time of the OR for the apical ones.
You place hybrid operation.
Hybrid.
Yes.
Yeah. So do you think about the poor LV and RV function is make the worsening of the operation results?
Yes, that's why I think I would lean toward the MRI, see what your EFs actually are, and then to look for any delayed enhancement, to look for any fibrosis.
Oh.
Would you agree that you have to do something though, or would you think of trying to leave this patient alone?
So that is the reason we bring the patient here.
I guess just to be complete, the only thing else that you could consider doing is an RV to PA shunt of some sort.
Yeah.
Just to add some pulmonary blood flow, because their main problem is the cyanosis, right?
So the first time is we very difficult. This is the first time in our life we see like that, because I think it's very difficult thing. So that's why I done the CT scan first for see clearly the anatomy for patient. So I try to make the CT imaging is same the echo for easy to my mind, because I'm an echo guy and not correct for the CT scan. So I asked to using the same view for me for easy for estimated. We can see the bridge from the posterior go up to the alveoli is make obstruction here, and we can see the flow from RV here go to the aorta, and we also see the VSD here, muscular VSD, and it's look like unrestricted VSD. So, and in the lower part we can see the one again that we confirm that is the part of the VSD closure, because the color, the thickening is different with the cardio muscle. So, and we check about the clension because we don't have the turbulent flow at the clension, but they quite a little bit dilated in the upper. So that is the reason we check the back again the clension and anatomy of the PA, and we can see the minoring in the SPC anastomosis go to the RPA, and the narrowing between the RPA and LPA. So that is quite popular when I see the patient done the bilateral SPC, maybe flow competitive tip in the middle, they make the narrowing in the middle of the PA. So patient on the slow dose of the diuretic and enalapril. So summary, this is a so we also done the RV trend for this patient, because look like it's in the apical of the patient look like aneurysm in the apical of RV. I don't know when they put the condyle is too low to apical or not. It make the aneurysm of the apical of the RV. So so in summary, this is a 15-year-old girl, 33 kg, with the DORV toxic being pulmonary atresia, multiple VSD, last SD, and the patient failing rastally operation with VSD closure, bidirectional clension. Currently now she have asymptomatic LVOT obstruction, impair of the LV and RV function, and patent bilateral bidirectional clension. So what is the option? That is the very difficult question for us. So
you say she's asymptomatic too. I'm sorry, but you said she's asymptomatic?
Yes.
But, okay. The only other thing that there's probably some significant aortal pulmonary collaterals too. So she probably already has some shunting left to right. But okay. I don't know that there's any medical treatment. For sure, one would consider either doing biventricular repair. That would be ideal. I think you would need a cath still. And failing that, I think at some point you're going to have to do an RV. You're going to have to add some pulmonary blood flow if you don't do a biventricular repair. This is a very tough case.
So the other option is we done the two step. First one, only we take out the patch for open up the LVOT first.
Where would you put the stent?
That means we maybe we plan for biventricular repair and redo rastally, but due to the very impairment of the LV and RV function, so now we take out of the VSD, all of the VSD patch first, because it makes the obstruction of the LV. So now we take it out first and cut off the bridging in the posterior. So then waiting 1 or 2 years later, so then we reduce heart surgical back again, or we can do it in the same time.
Yeah, that's an interesting idea. You would do that as a planning for staging a biventricular repair.
Yes.
If you were to do all that, I would probably add an RVP conduit also, and then you can go for many years before you have to decide whether or not to do the biventricular repair. That would be one way to do it. And do the LVOT resection, take down the patch, put an RVPA conduit, and then just, leave the VSDs.
Leave VSD, yeah.
It might be something that she could tolerate. I think it would be too much to do everything at one time. I agree with you. I think that would be too much, it'd be a lot of surgery to try to do everything at once to close the VSD. So that would be something to consider. Now you would have to sell her on this because she's asymptomatic, you said.
Yeah.
Mm-hmm.
What about in literature? You do not have to try it.
There's, the reason why there shouldn't be too much literature because this is a misdiagnosis, right? This is somehow they left and this is a cautionary tale when you have a big conoventricular septal defect, VSD, it's very common, at least 5-10%, to have additional muscular VSDs. And so I suspect they didn't see the additional muscular VSDs. And that's what caused the septum patch to bow, and then this other part of the LVOT obstruction occurred. So when you have one big VSD, you have to be very careful. You have to very carefully look for additional muscular VSDs. But there shouldn't be much literature because I think we don't get into this situation too much. And did you decide to catheter also, or?
Sorry?
Did you decide to do any cardiac catheterization?
Not yet.
Not yet.
Yeah. If we want to do the biventricular repair, we need to cath first because we estimated the pulmonary vascular resistance. Do you think we need to measure it?
We always would, but I'd be interested in seeing what the collaterals look like. And if then you do right before your surgery, take out the collaterals and then go on bypass and do what you propose. Usually if your lens are patent and you're okay, almost always your PA pressures are okay for two ventricle repair. You're not talking about doing a Fontan. And I guess that, just to throw it out there, the other option is to do a Fontan. That's a, I think that's something you should think about, whether or not you consider it. But that it's also a big operation, like you said. This is an older patient, and you would have to do a significant PA plasty. Maybe relieve the outflow tract obstruction also at the time, and then do the Fontan. So if you did that, you would also maybe think about staging to a Fontan.
Yeah, that is also a good idea.
Mm-hmm.
If we do the Fontan, so we don't need to start anything about the
I don't know. I'd have to see that area. You definitely, if the LV looks okay and if those VSDs are clearly non-restrictive, you could argue you don't do anything intracardiac, you just do the Fontan. Take out the collaterals, do Fontan. That would be something to think about.
Sorry, how about SpO2?
76.
That's why I think you're going to have to do something.
Yeah.
She's got hemoglobin 20.9. She's probably 76 on her best day.
Sorry, we have some case that if the patient has the gland and the SpO2 is too good, something like 90, 88 to 90, we need to proceed to Fontan.
Well, that just means you have a lot of collaterals, right? So the collaterals are a volume burden. So it's probably not an ideal place. I would catheterize the patient and take out the collaterals because then you reduce the volume burden. And if it's a young enough patient, our usual step is to go ahead with a Fontan because I think you still have a better, even with all the complications of Fontan, you still have a better long-term outcome.
Okay.
Yeah. It's a difficult case.
So, okay. Thanks, our colleague. Thanks for all the audience to stay up to now with us. We thanks Professor Lai. We are very honored, very, very pleased to have you in our hospital. We are a very young hospital, only 1 year old. And so I hope our team can profit from you, so many experience from you. I think that when we have a case, we think about it, we discuss about the case. It's important for us. So thank you very much, Professor Lai.
Thank you. These are all very good cases. Your images are impeccable.
Okay, thank you.
Very good. Thank you. Yeah. I was thinking more about this truncus patient. If you have that same patient again, something that you might consider doing is hybrid for that patient, just to get him older before you attempt the full repair. I don't know if sometimes when they do, what we've seen them do is bilateral bands, and then they narrow the PDA, so that then you can put your stent into the PDA. And that would be something to consider rather than a high-risk truncus. Let him grow another 6 months before you do the full repair. It might be a little easier step. I'm sorry to ask you about the result without knowing. Yeah, but this is, because this is a very difficult case. In any center, that would be very difficult. So you could temporize by doing a hybrid on that patient. Yeah, very good.
Em thưa thầy ạ, em xin phép thầy và giáo sư Lai là mời tất cả các thầy cô anh chị chụp chung một kiểu ảnh để
Đúng rồi. Đứng ở đâu em? Đứng ở đây. We take a photograph here.
Oh, sure. My question. Yeah.
Thầy ngồi hả?
Yeah.
Lên. Mấy người đứng sau. Okay, you sit here.
I see. Okay. Should we take this now?
Đây. Em hãy kéo ghế ra giúp chị nhé để nó đỡ bị vào hình. Vô đây. Đúng rồi, em với anh này. Anh chị đứng vào giữa đông ra nhìn ban tổ chức cho anh chán.
Last 3 years, Dr. Norman Silverman with us. We sit in the hospital.
Yeah, Norman and I have both have white hair now.
Yeah.
Chân vô luôn Vinh. Xin qua đây. Cái ngoài nó có che thầy không vậy em?
Chắc thầy thấy được.
Mỗi mình đeo khẩu trang rồi bỏ khẩu trang. Sang qua bên nào? Sang bên nào em ra sang qua bên. Xin cho chị mình. Xin cho em.
Thank you.
Thank you very much.
Thank you.
It's a pleasure. Thank you. Very good to see you again. Now I have to think. I used to think as Norm Silverman's the old person, but now I'm the old person.
Còn gỡ cho thầy.
Oh, that's very good. Very good cases. No, I think you're thinking about the cases in a good way. It's not easy to decide what to do in these cases, especially when you have to fix something that somebody else did a long time ago. Those are difficult cases to fix. Yeah.
So first of all, we because actually we never seen before.
Really?
Yes.
It is very. You will see it more often then. You will see it very often. It's at least you said it's 15%. It's about 10 to 15%. So if you see enough truncus, you will see more.